Hey everyone, we're going to review a clinical sim this morning and take some time to kind of pick it apart and see what we can do for this patient and prepare us for the exam. This patient is 80 years old and has been admitted to the hospital with shortness of breath and difficulty breathing unless they're in an upright position. And we know the medical term for that is orthopnea. So that's most common with cardiac patients. And of course, COPD patients need to be elevated as well in order to be able to breathe comfortably. A lot of times they'll be sitting forward and leaned over their bedside table to kind of elongate the chest and the lungs in order to be able to breathe a little more comfortably. But on the MBRC, we're going to reserve the term orthopnea or positional breathing for cardiac patients. The patient's also having chest pain, and the attending physician asked the RT to help with the evaluation. So in our stage 1, we're going to look at what we would evaluate. Our choices are vital signs, and the heart rate's 112, so that's a bit elevated, a little tachycardic. The respiratory rate's 26, also tachypnea, and the blood pressure is 108/68, so on a basis of 120/80. So we know that a lower blood pressure can sometimes be caused by heart failure. The temperature is 99.2, so we know that's slightly elevated above the normal temperature of 98.6. The creatinine kinase, we can choose to check that. It will give us a couple of points, and it is unremarkable at the time, so we know there's no damage to the heart tissue at this time. Response to painful stimuli, we're not going to check that. That would cost us a couple points, and the patient is alert and oriented. It doesn't tell us that they're unconscious, so we would not need to check their response to painful stimuli. The diffusion capacity, we're not going to need to choose that, so that would cost us a point. We have no reason to suspect the diffusion capacity to be decreased, plus that would take some testing in order to complete and evaluate, and right now we're in stage 1. We're going to be doing what's quick, inexpensive, and at the bedside. So going on, we don't need an EEG at this time. That would be checking the brain waves. That would cost us a couple points if we did choose that. Again, that's a lengthy test. It takes some time to do and get the results back. We're in stage 1 and we have no symptoms that would require an EEG. We do want to check general appearance. That would give us a point, and that would tell us that the patient is diaphoretic, so he's profusely sweating. We see that often in cardiac patients that are in distress. He has labored breathing, so we know there's some shortness of breath and dyspnea occurring at the time. Checking that general appearance gives us an extra point. We can check the chest x-ray. It shows cardiomegaly, and which is an enlarged heart. The heart is a muscle, so long-term hypoxemia and extra stress will cause it to increase in size. Cardiomegaly is the medical term for enlarged heart. It shows diffuse infiltrates. So diffuse means they're here, there, and everywhere. So that's more concerning than one infiltrate in one lobe. But diffuse infiltrates is telling us that they're across the x-ray. We don't want to check bowel signs. That would cost us a point, and it's not needed in this situation. We will check breath sounds. It's scattered inspiratory crackles, and so that would give us an extra point, and that tells us that there's some fluid in the alveoli, so we need to find out why. We're going to choose also to assess pedal edema. That's something we can do by observation. We might want to lay a couple fingers on that area and press and see how far the fingertip indentation is made in the edematous area, and that would give us a couple of points for checking that, and it's telling us that the pedal edema is +2. So we've got some fluid on board between the inspiratory crackles, the diffuse infiltrates, the patient's in distress, and pedal edema of +2. We know we've got some hypervolemia. So we look on down our list of things we can choose, and it's telling us that the next choice is sensorium. We could go ahead and check that. That would give us a positive point. And right now, the patient is mildly confused. So there's probably some hypoxemia going on causing that mental confusion. The next choice is a pulmonary angiogram. We're not going to do that. That would cost us a couple points to choose that. That's more of a stage 4 choice. We're just in the stage 1 of assessing the patient initially, and so we're going to just leave that there and not choose it. Pulmonary angiograms take a lot of time, they're expensive, and it takes a while to get the result back, after it's been evaluated. It requires the patient to go to angio for the testing, so it's kind of a big deal, and we really don't need that right now, so don't choose it. The next choice it gives us is an MVV. We do not want to do an MVV at this time. That is part of a spirometry test. We have to do that in the PFT lab, and of course we're in the emergency room with a patient that is not having those types of symptoms at this time, and that test would exert the patient excessively, and they're already in distress. So don't choose the MVV. That's part of a spirometry down in the PFT lab. The EKG, it would be good to choose that at this point. It would give us positive 2 points, and it tells us that the patient has sinus tachycardia and significant Q waves. So we know that the heart's under stress. It's beating faster than it should be. Remember, our heart rate was at 112, and normal heart rate is 60 to 100. So we have a significant Q wave, which tells us that there is definitely some damage done to the heart, either in the past or currently. The arterial blood gas, we'll go ahead and choose that. That'll give us a couple positive points. On 2 liters per minute, the pH is 7.47. The PCO2 is 33. The PO2 is 52, and the bicarb is 24. So we know there that our pH is out of range. It's a little high at 7.47 when our normal pH range is 7.35 to 7.45. Our PCO2 is 33, so it's a little low. Of course, our range is 35 to 45. The patient's hyperventilating some because they're in distress. So our PO2 is our issue. The PO2 is 52, so it's definitely too low. The patient is hypoxemic. And the bicarb is 24. So in looking at this blood gas, let's keep in mind, we know that ventilation is priority, but if the ventilation is out of range because it's too low, that's less of a priority than if it were too high. So too low just means the patient's overventilating, and that's not as important as if the patient was hypoventilating. So we're going to just keep that in mind, that the patient's hyperventilating, and we're going to just move on and correct the oxygenation problem. That's our priority in this situation because it's only 52. So the one other thing we're going to check on our list is the cough is weak and non-productive. Checking the cough will give us a bonus of 1 positive point. So in describing this scenario, the patient's telling us, and we see that he is short of breath, he has orthopnea, has to set up in order to breathe comfortably. or semi-comfortably. He has chest pain, and that indicates a breathing problem, a cardiac problem, or possibly both. So by checking the vital signs and then checking the creatinine kinase, that the creatinine kinase rules out the recent MI. Now, we talked about that we have some significant Q wave changes, but that could be from a past situation. The general appearance, chest x-ray, breath sounds, the pedal edema, the confusion, the EKG abnormality of sinus tachycardia, and significant Q wave, the ABG, and the cough all work together to tell us that the patient is mildly hyperventilating, so there may be some hypoxemia, and this is the patient's effort to get more oxygen into the body. So the normal bicarb of 24 tells us that there's not any long-term compensation, so this is recently began. It's an acute abnormality because the bicarb has not had time, the kidneys have not had time to kick in and begin correcting the problem. That's kind of a longer process. So we may not see that bicarb move initially. And the important information from the EKG is that we see by the significant Q wave that there likely has been an MI, plus we're seeing the pitting edema in the ankles, and that's pointing us toward congestive heart failure. The crackles and the presence of cardiomegaly and diffuse infiltrates on the chest x-ray also tells us there's likely some CHF. So make sure that you take into account the diaphoresis, confusion, labored breathing, and weak cough effort. All of these are showing us that there is a situation that needs corrected as soon as possible. So next, the doctor's asking us, what would you initially recommend? Well, remember, we have a PO2 of only 52. So the first thing that we're going to recommend is applying a 100% non-rebreather to try to correct the PO2 problem and make the patient more comfortable. Hopefully by correcting the PO2, then the PCO2 will be corrected because the patient will slow down their respiratory rate and stop the hyperventilation. So by definition, we know that PO2 less than 40 is severe hypoxemia on room air. So with this, the patient's already receiving oxygen by nasal cannula at 2 liters per minute, but the patient has the PO2 of 52. So you know that the severe hypoxemia exists, and this will have an adverse effect on the heart. It's going to continue to put this patient under stress. So we've got to correct the hypoxemia first. And in this case, the non-rebreather is the best way to do that. We don't want to intubate or use a mechanical ventilator at this point. We're going to try to avoid mechanical ventilation and intubation if possible. The other choices we had was to give the patient a bronchodilator treatment. We would not want to do that because there is no wheezing and our problem is cardiac. Nasal oxygen at 4 liters is another choice that they gave us in our first recommendation. We wouldn't want to do that. It's just not enough oxygen to correct a PO2 of 52, especially considering that there's too much fluid on board. So they also give us the choice of a VQ scan. We don't want to do that right now. So there's no indication to spend that much time and use that kind of intervention at this time. So the doctor asked, what is your recommendation for what's causing the patient's breathlessness? What do you think this diagnosis is? And we've already discussed, we know the patient has the signs and symptoms of CHF. And that gives us a couple of bonus points, positive points for choosing that. It gave us other choices, emphysema. We know it's not that. It doesn't have the right signs and symptoms. ARDS, chronic bronchitis, pulmonary embolism, pulmonary hypertension. So it's very important to know the signs and symptoms of each pathology. That way you choose the right one when you're asked what the diagnosis is likely. So we have all the key ingredients for CHF, including cardiomegaly, diffuse infiltrates, and the prominent pedal edema. So it asks us next, in addition to supplementary oxygen, which of the following is the most important to continue treatment of this patient? And we know that to treat CHF, we need to remove the fluid that's causing the problem. So we're going to recommend diuretics. We're going to recommend that the patient gets intravenous Lasix or furosemide as soon as possible. We know that IV is the only way, the quickest way to get medication on board. So we've probably already got a line in. They're in the emergency room, so we need to go ahead and give the IV Lasix. And remember that the generic name for that's furosemide. So it gives us other options. Bronchodilators, well, there's really no wheezing. CPD and postural drainage, we don't need that. Analgesics, no, we don't need that. Corticosteroids, there's not any evidence of inflammation. And mucolytics, remember they had a non-productive cough, so there's not an issue there. So diuretics is what we need. Aggressive diuretic is a treatment choice for CHF and the key to removing excessive fluid from the body via urination. Okay, so moving on, the patient's condition is showing improvement following aggressive diuresis, and he's transferred to the ICU. The supplemental oxygen is being administered at 4 liters now, and the saturation is at 94 to 96%. So he's shown enough improvement in order to be able to remove the non-rebreather mask and change it to 4 liters. And he's holding steady at a sat of 94 to 96, so that's great. The following day during oxygen rounds, the cardiac monitor is heard alarming in the patient's room. Upon entering the room, it is noticed that the patient is sitting upright in his bed, holding to the side rails. His gown has fallen away from his upper body, and his upper torso is glistening in sweat. So he's diaphoretic again, and he's scared, he's anxious, and he's very short of breath. The cardiac monitor indicates sinus tachycardia, so that's telling us that the rhythm is fine, but it's just too fast because the heart rate is now 120. The patient's having multifocal PVCs and elevated ST segments. So that's telling us there's some ischemia going on, and there's hypoxemia that more than likely that's causing the PVCs. We know hypoxemia is the #1 cause of premature ventricular contractions. So with the patient's fully alert and complains of chest tightness and severe left shoulder pain. Auscultation reveals a few bibasilar crackles, and the patient's respiratory rate is showing tachypnea at 24 breaths per minute. Based on these findings, which of the following should be recommended initially? And we're going to go ahead and recommend an anticoagulant therapy. The patient is showing symptoms of an ongoing infarct, and so we need to go ahead and get an anticoagulant going. The other options it gives us is a cardiac cath, which would cost us a point. We don't want to start initiation of CPR because he has a heart rate. That would cost us 2 points. Pulmonary angiogram would cost us a couple points. We don't need that right now. A stat chest x-ray. We've already had a chest x-ray earlier, and we knew that the patient had extra fluid on board, even though he's been getting a diuretic. It seems like it tells us that he's having a few bibasilar crackles, so there's still a little bit of fluid on board that shouldn't be there. So we're going to continue the diuretic. And then an arterial blood gas at this time would cost us a couple points as well. So the most important piece of information at this point is taken from the patient scenario, telling us that the cardiac monitor indicates elevated ST segments, or an ongoing infarction. A pulmonary angiogram, chest x-ray, and ABG are all diagnostic and offer no therapeutic relief. Therefore, those would have all been the wrong choices. With an ongoing MI, the immediate priority is to dissolve any thrombus or clot that exists and reduce the chance of reoccurring using anticoagulant therapy. CPR is definitely not indicated, and cardiac cath